deep venous ultrasonography to diagnose DVT. Not the most exciting modality in point-of-care ultrasound, but as I hope to demonstrate, there are a few specific scenarios where knowing how to diagnose a DVT acutely, I think will serve you well. So this slide is just this is fairly old data, but I think it still applies, and maybe even more pertinent now is the incidence of DVT in the critical care setting. This first study is in the medical critical care setting, but there are subsequent studies that show similar sort of numbers, that even in the era of adequate DVT prophylaxis in the critical care patient, the critical care population, the incidence of DVT is as high as 20%. So this is definitely a diagnosis that you'll be faced with. But why should we as intensivists learn how to do DVT ultrasonography? So of course, just like any other point of care modality, our ability to diagnose it means it's fast. We can do it 24/7. And I'll show you some data that tells us that we can be just as accurate as radiologists and techs doing this study. But there are very few situations where the diagnosis of DVT is an emergency diagnosis. But it's that fourth point where that scenario where you are training for. This is the patient who is unstable, who is hypoxemic, who you may have done an echo on and see a dilated RV, and you're concerned about a massive PE, but they're too unstable because of hypotension or hypoxemia or both to go to a CT scanner to diagnose the PE. In this patient, if you were to be able to diagnose a DVT, you would have a higher, sort of index of suspicion for PE, and you'd be on more solid ground to push TPA. So this is the type of patient that you're training for when you're trying to learn how to do DVT ultrasound. And depending on the critical care setting that you practice in, you will see this type of patient, at least on a yearly basis. So when you order a formal DVT ultrasound, a tech comes and does the scan, and the radiologist interprets it. This is what you get. You get a three-component study. The cornerstone of the study is number one, 2D imaging with vein compression, where you image various high-yield locations in the lower extremity deep venous system, and you compress, trying to assess for both visibility of clot and compressibility of the vein. They also do a Doppler spectral analysis, trying to demonstrate blood flow velocity and direction, and to identify spontaneity and phasicity of venous flow. And finally, you get color Doppler, which is done to do mapping of venous flow and direction. And they also, in some protocols, they also do what's called an augmentation maneuver, where they put color on the vein and they either squeeze the calf or dorsiflex the foot to augment venous flow. So you get three components to it. At the bedside, we only do the first part. We only do 2D imaging with compression, without color, without Doppler. Our goal initially, of course, is to rule in DVT, but as we get better, we can start to rule it out. And what we're looking for is for proximal lower extremity DVT. So are we good at this as intensivists, as clinicians? Well, there's been a number of studies. These two studies, the first one in the ED setting, the second one in the medical critical care setting, showed that with some concentrated training, both didactic and hands-on training, ED physicians and intensivists can be as accurate as sonographers and radiologists in picking up lower extremity DVT in the ICU setting or in the ED setting. Should we be using color and Doppler? There have been a few studies that have examined this. The same groups on the ED and the ICU, and also a group that looked at it in general medical population, demonstrating that there was no added sensitivity or specificity to the bedside study when you added color and or Doppler to your study. So the bottom line is, when we do it at the bedside, we use two-dimensional imaging with compression to assess for DVT. There is no added yield to color and Doppler. All it does is just adds time to your study, which we don't really have a lot of. So before we start scanning, there's really two important things that you should be acquainted with when you're doing a DVT study. One is, of course, knowing the machine, like any study. but I'll show you here that gain and depth are very important when you're trying to assess for DVT. And the most important thing is you need to know the anatomy of the lower extremity deep venous system. This is the key to success, and not knowing the anatomy is what will get you in trouble. So we'll talk about that. Here is the pertinent anatomy for us when we're scanning the lower extremity deep venous system. Here is the right lower extremity, and the pertinent anatomical landmarks, excuse me, are in the red boxes. As you'll see, we start with the common femoral vein. And as we go down the femoral vein, we want to identify certain high yield points, which tend to be branch points or tributary inlet points. And these are points where you are most likely to form clots as you go from sort of laminar flow to turbulent flow as velocities change, as flows converge and things like that. So we start with the common femoral vein, and this is usually the best place to find this is right at the inguinal ligament. And what you're doing is you're doing a transverse view of that vein, starting with the probe roughly parallel to the inguinal ligament at the common femoral vein. From here, generally all it takes is an angle downward to go from the common femoral vein to identify the great saphenous vein inlet. And the great saphenous vein will drop into the common femoral vein superficially and medially. So on the right leg, it will drop in at 2 o'clock. On the left leg, it'll drop in at 10 o'clock. From there, you will slide down the common femoral vein. And the next point you want to identify is the bifurcation between the deep femoral vein and the superficial femoral vein. And then you're going to continue marching down the superficial femoral vein, compressing as you go about every 1 to 2 centimeters, looking for clot and looking for compressibility. As you go down on the leg, the deep femoral vein will sort of quickly dive into the muscle tissue and you'll lose it. And you continue following the superficial femoral vein until you lose it. Typically, the femoral vein visualization gets lost at about the lower 2/3 of the thigh. Okay. I do want to point out this term superficial. So this term superficial has confused clinicians for some time. They'll see a report on an ultrasound report that'll say something like there is a clot in the superficial femoral vein, and they'll see the term superficial and think, oh, it's not a deep vein. So most centers now take out that term and they refer to this vein as simply the femoral vein. So that's what I'll refer to it from now on in this talk, the femoral vein. So you just follow the femoral vein until you lose it. And then once you lose it, you go back in the popliteal fossa and identify the popliteal vein. Okay. These are the required views. You can sometimes identify the trifurcation of the popliteal vein in the popliteal fossa. Sometimes that trifurcation, the branching into 3 branches, occurs further down in the leg. But if you can see it up here, identify that and compress it. Determining veins versus arteries on ultrasound is generally fairly uncomplicated. Typically, veins are larger than arteries, than the accompanying artery. They have thinner walls than arteries, and they have valves. Arteries, of course, don't have valves that are visible on ultrasound, or valves for that matter. Veins, normally at least, are compressible or collapsible. And if you do see motion in the veins, you're going to see respiratory motion, as well as transmitted cardiac motion sometimes from the artery. So you may see sort of externally applied pulsatility in the vein, but you will also see phasicity and respiratory motion. So in general, though, veins are larger and thin-walled, and you'll see valves. Whereas arteries tend to be thick-walled, they're more distinctly round in shape, and of course, no valves. So to scan, you want the patient to be supine or at the most at about 30 degrees of a head of bed elevation. You want, of course, to fully expose the leg to above the inguinal ligament. And the best position of the leg is in a frog leg position where the leg is externally rotated and the knee slightly bent. You're going to use a linear transducer. If you have the option, you want to use this wider footprint linear probe. So on our machines, we have both a wide footprint probe like this one and a narrow footprint one. The narrow footprint one is good for very superficial structures like the IJ, like the eyeball, Whereas the wider footprint transducer gets you a deeper field of view. So if you have the option, use that wider footprint probe. Everything that we do with DVT is done in the transverse plane. So back to the body ultrasound convention, transverse plane means the dot will point to the patient's right side. So we start up at the inguinal ligament and we go down, identifying those high yield points that we were talking about. You want to view the vein. You want to look in the lumen and determine that the lumen is anechoic. And you want to press down on the vein. The way you press down, you want to make sure that when you're actually compressing on the vein, the force is directed 90 degrees to the leg. Because in that way, when you're compressing 90 degrees, you're actually looking where you're compressing. If you're angled and you're compressing, what could happen potentially is that you're looking downstream and you're compressing, below the probe, and it can make it look like the vein is not compressing when you're pushing down. So make sure that your probe is angled 90 degrees to the skin when you're compressing. You want to push down until the vein collapses, or if you're pushing down enough for the artery to deform, but the vein isn't collapsing, that is a non-collapsible vein. Okay, so visualize the vein in transverse axis, look at the lumen, make sure it is anechoic. And this is where the setting of gain is important. Remember, you want to set the gain so that fluid-filled structure is anechoic. You want to set it low enough that fluid looks anechoic, but you want to set the gain high enough that the vascular wall is clearly visible around and differentiable from the lumen. Okay, if you set the gain too high, you can make it look like there's echogenic material in the lumen. So you don't want to do that. You want to set the gain optimally. Okay, so look in the vessel, make sure it's anechoic, and then compress it 90 degrees. And you're just going to continue to follow the vein down, compressing about every 1 to 2 centimeters as you go, and obviously do both legs. A negative or normal study / vein, the lumen is going to be anechoic and it's going to be fully compressible when you push down on it. Okay, an abnormal study means that you see echogenic material in the vein, especially if that echogenic material is well demarcated. And when you push down on it, it's not going to be fully compressible. So again, when you push down, the artery is deforming and the vein is not collapsing, that means it is not collapsing. Okay. And an important thing to remember, really with any modality of ultrasound, but DVT in particular, is that if you see something that's abnormal, if you see echogenic material or a non-compressible vein, look at it in 2 planes. So if you see that in transverse axis, rotate the dot so it points up to the head and look at it in long axis. Okay. So we start with the femoral views. Again, up at the common femoral vein, at the inguinal ligament, angle down to get the greater saphenous vein, continue sliding down to the bifurcation of the deep and superficial femoral veins, and then continue to follow the deep femoral vein until you lose it. Again, scanning every 1 to 2 centimeters as you go. Here's a position, patient supine, no more than 30 degrees of head elevation, frog-legged, so externally rotated leg with the knee slightly bent. And then the dot here is pointed to the patient's right side. Here's your first view. They call this the peanut view because it looks like a peanut. Here's the common femoral vein here and the femoral artery right next to it. This is the right leg. So this is lateral, this is medial. Common femoral vein, common femoral artery. These 2 vessels in most patients are very closely approximated together. And so what happens is, because you have a fluid-filled structure here, approximated up against another fluid-filled structure, and the wall in between them is parallel to the sound waves, you can get dropout of that wall and can make it look like it's one continuous structure. So this is actually an artifactual, sort of finding that you don't see the wall. So it makes it look like a peanut with the shell intact. Okay, so common femoral vein, typically, like I said, at the level of the inguinal ligament, you're going to find this and compress it. And that's what that would look like. You can see that as you push down, that vein is nicely collapsing. You want to push down enough so that the 2 walls touch and then let up to let it rebound. As you angle the probe downward, you're going to start bringing in the great saphenous vein, which, like I said, empties medially and superficially into the common femoral vein. So this is the right leg. It's going to empty in at around 2 o'clock. Very high yield place for the formation of clots. It's really important that you visualize this and compress here. A lot of clots form here and get bigger. So find this point and compress it. As you start moving distally, you're going to move down on the superficial femoral vein, common femoral vein, until it bifurcates into the deep femoral vein and the superficial femoral vein. You can see it bifurcating here. Typically, the artery will bifurcate first. So as you're sliding down the leg, you're going to see the artery bifurcate first. Then you will see the vein bifurcate into the superficial and the deep. Again, high yield place for clot formation because it is a branch point. So you want to find this and compress here, making sure that both veins are fully compressible. And you continue to follow the femoral vein as you go. This slide shows you that as you go more distal, the femoral vein is going to get deeper and deeper in your field of view. So what you want to do is continue to increase your depth so that you keep the femoral vein in the center of the screen, unlike what's shown here. So increase your depth to keep this centered up and down, and make sure that you are centered left and right. Because again, when you compress down on the vein, you want to make sure all that force is being exerted axially right down into that vein, so center. And then when you center it up and down, your visualization is going to be, your resolution is going to be the highest. Okay, once you've followed the femoral vein down and lost it, like I said, in most patients, that happens about 2/3 of the way down the thigh, go into the popliteal fossa and find the popliteal vein. And if you are, have a patient with the, sort of classic anatomy, you should find the trifurcation point as well. But like I said, in some patients, that branch point occurs further down the leg. So in that case, don't worry about it. Okay. There's one of two ways you can position your patient for the popliteal view. If you have a patient that is cooperative, conscious and cooperative, you can tell them to slightly flex their knee and put their foot on the bed. And you can go from underneath here, pointing the dot to the patient's right side. Or you can extend or make that frog leg position even more externally rotated, and then extend that knee just a little bit so you can fit into the popliteal fossa. But you're going right in the middle of the popliteal fossa, dot pointing to the patient's right, looking for the popliteal vein and artery. The anatomy down here becomes a little bit more variable than it is up in the thigh. So sometimes you will see vein and artery right next to each other. Sometimes you'll see vein on top of artery, sometimes the other way around, but you're looking for two vessels, okay? If you put your probe in the fossa and all you see is the artery, odds are you're already compressing the vein because normally the popliteal vein is very easily compressible. So if that happens, just let up on your pressure a bit and that vein should open up, okay? So femoral vein and artery, and of course you want to compress there so that the vein collapses. That is a fully compressible popliteal vein. And then, like I said, if you angle down in the fossa, you may pick up where that vein branches into 3 branches. Okay. So let's look at some abnormal studies. Here's an example of a thrombus in the common femoral vein. This is in the left leg. So a nice adherent, really well demarcated echogenic structure in the vein. You can see some degree of calcification here. So this may be a chronic DVT, but again, that's not our job. Our job is to find clot or not. So you can see adherent to this wall here. That lumen is not fully anechoic, of course. And if we were to try to compress there, it would not fully compress. Okay. There is a concern and a theoretic risk of dislodging a clot if you compress on it. I will say that it's probably not a big concern unless you keep compressing on it. So if you find a clot, try once or twice to compress the vein. And if it doesn't, call it non-compressible. This is probably not the patient where you want to call in every medical student into the room to show it to them and show them that is not compressible. But just find it and compress it once or twice to demonstrate non-compressibility. Okay. And then, like I said, if you see an abnormality, look at it in 2 planes. So here's that same clot visualized in the long axis. So here's the common femoral vein. You can actually see this is the inlet point of the greater saphenous vein. So this clot actually originated at the greater saphenous vein. And if you look here, you can see there is a little valve fluttering. So this is a common femoral vein DVT that likely originated at the inlet of the greater saphenous vein. So if you see an abnormality, look at it in two planes. Here's a clot in the great saphenous vein. You can see left leg, great saphenous vein here. You can see that the vein itself is engorged. It's huge. And then again, you can see an echogenic, clot here, adherent to the wall in the great saphenous vein. And as you try and push down on it, the vein is not fully compressed. You can see here the artery is already bifurcated at this point. Okay. Here's a popliteal DVT. You can clearly see echogenic material in the lumen, and the vein is not compressing. Okay. As far as documentation, you want to visualize all of those required views that we discussed. Common femoral vein, all the branch points. You want to get at least one clip of the superficial femoral vein distal to the bifurcation, a representative clip of that, and a clip of the popliteal vein. Of course, if you see any abnormality, document that, the visualization and the lack of compressibility. And if you see an abnormality, visualize it and document it in two planes. Okay, so if you see a clot in the transverse axis, turn the dot up to the head and visualize it in long axis, just to confirm that you're seeing what you're seeing. Okay, some pitfalls of DVT ultrasound that are relatively common. Sometimes if you have an obstructive DVT, that can cause engorgement of these superficial veins. So if you're not looking for the expected anatomic findings, you may see a superficial vein that's engorged, mistake it for a deep vein, and compress it, missing the large occlusive DVT that's in the deep venous system. Okay. So this can sometimes happen if you have a large patient, if they're obese or if they have a lot of edema, and you haven't set your depth deep enough to actually visualize the deep veins. And of course, you're not keeping the anatomy straight and just looking at the first vein that you see. Okay. Lymph nodes, especially if you have lymphadenitis, can sometimes look like veins with clots inside them. And of course, if you try to compress it, it's not going to compress. But if you were to look at a lymph node in long axis, it'll still look round compared with a vein that will look long. And of course, you will not see the normal anatomic markers if you're looking at a lymph node. So again, keep the anatomy straight. And if you see an abnormality, look at it in two planes. Okay. If you have any questions, again, come find me, shoot me an email. Otherwise, I look forward to scanning with you.